Okay, a very good evening to everyone. So we have had a very long day of academics, and the next session is very interesting, erectile dysfunction, but after today's long day, we might be having brain dysfunction. So just to get rid of the dysfunction, can anyone tell me how long have we been using sulfonylureas? How many years roughly? Ages, how many? 100 years insulin, sulfonylureas? Okay, so actually we have been using it for nearly 70 years because it was that long back when tolbutamide was launched in Germany. Familiarity breeds contempt. So since we have been using it for so long, it has become familiar. Newer molecules, we have been discussing them from today morning. They are more popular now. And the other reason why these molecules have got sort of a bad name is because of the older molecules that were there. Yes, they did have their problems. They did cause hypoglycemia, weight gain. Some of them might also have contributed to beta cell apoptosis, but it's different when we talk of the newer molecules like Glimepiride. The basic reason being because the way they bind to the beta cell, the way they are released from the beta cell is different compared to the older sulfonylureas. And it also reflects, if you look at the data, because there is clear evidence that a newer sulfonylurea like Glimepiride or gliclazide for that matter causes far lower hypoglycemia compared to older one like glibenclamide. Even in terms of weight gain, the standard teaching in the pharmacology textbook is that when you use a sulfonylurea, you get a lot of weight gain. But that pertains mainly to the older sulfonylureas like glibenclamide or tolbutamide or chlorpropamide. With newer sulfonylureas like Glimepiride or gliclazide, we have 5-year or even longer data to show that they do not contribute to weight gain. We know that in terms of efficacy, they are second to none. We know SGLT2 inhibitors have excellent efficacy, and if you look at head-to-head trials, Glimepiride has as good efficacy as, say, a full dose of empagliflozin or 100 milligrams of canagliflozin. If you compare it with 300 milligrams of canagliflozin, canagliflozin has 0.1% extra A1C lowering, but you are comparing a 100 rupee drug with a 5 rupee drug. When you compare Glimepiride to DPP4 inhibitors, Indian study sitagliptin versus 1 to 2 milligrams of Glimepiride, small dose of Glimepiride. Over the first 3 months with Glimepiride, there was additional HbA1c lowering compared to that seen with sitagliptin. And if you look at the adverse effect profile, weight gain, patient reported hypoglycemia was similar between sitagliptin and Glimepiride. So we have been also taught that sulfonylureas cause hypoglycemia. Yes, they do cause hypoglycemia, but it depends on the perspective where you are using it. If you use low doses of Glimepiride, 1 to 2 milligram in patients with good renal function, the risk of hypoglycemia is actually low. A major mistake which is often done is that we often give very high doses of Glimepiride to begin with. If you look at the data, low doses of Glimepiride are as good as high doses of Glimepiride. There are studies where 1 milligram of Glimepiride has been compared with 4 milligram and 8 milligram of Glimepiride. Practically, there is not much of a difference. With 1 to 2 milligram of Glimepiride, the efficacy is nearly 80% or more, as much as say 4 or 8 milligrams of Glimepiride. The higher doses of Glimepiride will give you additional glucose lowering, but it might not be clinically relevant and might come at a much higher risk of hypoglycemia. So the message from the earlier study and this one is that if you stick to low doses of Glimepiride, you get almost similar efficacy with a much lower risk of hypoglycemia. Now this was a study which we did in patients with mild to early moderate renal dysfunction, where we used low doses of Glimepiride in one arm, we used vildagliptin in the other arm, and in another arm, insulin was used. It was found that, and this was a CGMS based study, it was done in 2018 where the 3-day CGMS was more popular. And it showed that the rates of nocturnal and overall hypoglycemia was similar with vildagliptin and low dose Glimepiride. Again, this was continuous glucose monitoring. So overall, the hypoglycemia did not increase. Interestingly, we also found that the variability, glycemic variability was also similar between vildagliptin and Glimepiride. When we talk of vildagliptin, we often say that it is one of the most potent agents in reducing glycemic variability, but as our study showed, so is Glimepiride. Again, low doses give you good glucose control, as good as higher doses, almost as good as higher doses, reduces glycemic variability without a significant increase in the risk of hypoglycemia. Another notion that we have is that in long-standing diabetes, is glimepiride going to work, or for that matter, is a sulfonylurea going to work? So this is an interesting study, although a small one, 56 participants, where the patients had about 10 years of, nearly 10 years of insulin use. The duration of diabetes was definitely much longer. They had uncontrolled HbA1c, and the mean dose of insulin was as high as 67 units in these individuals. They were divided into two groups. So nearly 10 years of insulin use, uncontrolled HbA1c, 67 units of mean dose of insulin in these individuals. In one group, they were given glimepiride from 1 to up titrated to 4 milligram. In the other group, insulin was up titrated. So what was seen after the end of 6 months? The group which was given glimepiride instead of insulin up titration attained better glucose control, required lower doses of insulin, had lesser hypoglycemia, had lesser weight gain, and most importantly, what was an interesting finding was that adiponectin levels increased when glimepiride was given, but did not do so when insulin was up titrated. We know that adiponectin is a adipokine which improves insulin sensitivity, reduces insulin resistance. And this is not a one-off phenomena. If you look at earlier studies, this is a study from 1995, way back from 1995. This study compared different sulfonylureas, and the yellow bar which you see there is the amount of insulin released by the sulfonylurea. The blue bar which you see is the glucose lowering by that sulfonylurea. And if you look at these ratios, it was found that for the amount of insulin released, glucose lowering was the greatest when glimepiride was compared to the others, which simply shows that it's not only a beta cell insulin release that is acting with glimepiride, it possibly has some peripheral actions. And if you look at the earlier study, there was increased adiponectin. There are studies which have also looked specifically at glimepiride versus glibenclamide, larger data sets which have again showed the same finding. If you use glimepiride compared to other sulfonylureas, you increase the levels of adiponectin. It might have a peripheral action in improving insulin sensitivity, reducing insulin resistance. It does not act on the beta cell alone. There are also studies which have shown use of glimepiride upregulates the glucose transporter 4 at the level of the muscles. So even in very long standing diabetes where the beta cell mass might have reduced, it does release some insulin, and importantly it might have peripheral actions in improving insulin sensitivity. We had a session on glimepiride earlier in today, about an hour back, and there also we discussed about the cardiovascular safety of glimepiride. Some more data just to show that compared to the older sulfonylureas, the newer ones like glimepiride and gliclazide are safe from the atherosclerotic cardiovascular disease viewpoint. This again is an interesting study where glimepiride and gliclazide were compared with regard to the risk of arrhythmia, ventricular ectopic beats in patients with heart disease using Holter monitoring. It was found that when patients were put on glimepiride, the number of ventricular ectopic beats came down. When they were shifted from gliclazide to glimepiride, the number of ventricular ectopic beats came down. So possibly there could be some anti-arrhythmic action when it comes to the action of glimepiride, but again this is a small study, needs further investigation. Heart failure, diastolic heart failure, glimepiride and liraglutide were compared, and it was found that there was no difference in the echocardiographic parameters in patients with diastolic heart failure when glimepiride was compared with liraglutide. And earlier Dr. Rajan very nicely showed us the study where in patients with chronic heart failure, glimepiride improves morbidity, improves survival, with arachidonic acid metabolites having to play a role there. Carolina already discussed. A revision once more. If you look at the study, 1/3 of the patients had established atherosclerotic cardiovascular disease, 1/3 of the patient had high cardiovascular risk. Glimepiride was compared with linagliptin, and we all know that overall in terms of safety, linagliptin and glimepiride did not differ in atherosclerotic cardiovascular disease outcomes. Linagliptin had already proven its cardiovascular safety earlier in the Carmelina trial, so you could extrapolate that Glimepiride and Linagliptin are as safe in terms of cardiovascular outcome in the sort of garden variety of diabetes that we get to see in our day-to-day practice. But if you look at this trial more closely, there is further data that needs to be seen, which is that if you look at the pattern of A1C lowering, if you compare Glimepiride with Linagliptin, the HbA1c reduction in the first 8 months was much more with Glimepiride compared with Linagliptin. So we keep on talking of early HbA1c control, legacy effect, good metabolic memory. So if you consider a drug like Glimepiride, early A1c lowering better than something like Linagliptin will contribute to better metabolic memory. More importantly, we talk of durability. So here we have 5-year durability data that Linagliptin is as durable or Glimepiride, or rather Glimepiride, the sulfonylurea is often said to be less durable, is as durable as Linagliptin. So earlier glucose control, similar durability is additional data from the Carolina trial. We now know that it's not entirely beta cell apoptosis which contributes to beta cell dysfunction. Some of the beta cells in response to a glucose load get de-differentiated into an alpha cell or a delta cell. And if you can reduce this glucotoxicity quickly, these cells can re-differentiate to a beta cell, and herein lies the importance of early HbA1c lowering. The Carolina trial also showed that in the elderly to the very elderly who had a big representation in the Carolina trial, Glimepiride was safe, and we have a publication from Dr. Mohan's clinic from South India, which included only patients who were 90 years and above. So in this 90 years and above patient group, about 85% were on oral anti-hyperglycemic agents, more than 2/3 of which was sulfonylurea. So you don't need further proof. The durability of action and the very fact that people are alive beyond the age of 90 years on sulfonylureas goes to show that they do work, and they do work over a long period of time. Finally, the last set of data that I am to show you before I wind up my presentation, the GREAT trial. Now the GREAT trial was designed to answer the question, what after metformin? We have often had debates in different conferences, what after metformin? So patients on an optimal dose of metformin, not well controlled, were randomized to 4 different arms. They could get sitagliptin, insulin glargine, injection liraglutide, or Glimepiride, which would be gradually up titrated. The only problem with the GREAT trial was that it did not include a SGLT2 inhibitor, for the simple reason that when the GREAT trial began at around 2012, there was no approved SGLT2 inhibitor available for use commercially. So if you look at the results of the GREAT trial, the drug which failed first in terms of durability of action in reducing HbA1c, interestingly, was sitagliptin. The drugs which failed later were Glimepiride, followed by glargine and liraglutide. And if you look at the difference between sitagliptin and Glimepiride, Glimepiride gave you an additional more than 100 days of glucose lowering compared to a drug like sitagliptin. More patients on Glimepiride attained the A1C of less than 7 compared to sitagliptin. And higher the HbA1c levels, the actions of Glimepiride were even more better compared to sitagliptin. And if you look at the outcomes, the vascular outcomes over this period, they were more or less similar between the groups, with only liraglutide having an edge in terms of improving cardiovascular outcomes. So the GREAT study clearly shows that if you consider drugs after metformin, it's not the DPP4 inhibitor which is more durable. Interestingly, it's the Glimepiride sulfonylurea which is more durable. It's not only more durable, it's more effective in bringing down the HbA1c to lower levels. If you look at the cardiovascular outcome trials that we all talk about day in and day out, nearly half of the patients in all of these cardiovascular outcome trials were on modern sulfonylureas. Unless you are on a modern sulfonylurea, your HbA1c is not going to come down. And if you look at all these cardiovascular outcome trials, none of them included patients with grossly high A1Cs. The A1Cs were around the 8.5 mark. If these sulfonylureas were not there, I think if the baseline A1C was say around 9.5, 10, the results might still have been somewhat different. Finally, genetics. Any lecture nowadays is not complete without touching upon genetics. This is an interesting study from a United Kingdom database which shows that if you carry a certain type of mutation, a mutation in the ABCC8 gene, the ABCC8 gene codes for the sulfonylurea receptor. And there is a certain mutation in this gene which if you carry that mutation, you have a mild state of sulfonylurea receptor activation right from your birth. So it's as if you are on a very low dose of sulfonylurea right from your birth in a certain cohort of individuals. It was found that if you carried this mutation, as expected, you had a lower risk of developing diabetes, you had higher BMI but lesser waist hip ratio, you had lesser central obesity, and importantly, your risk of developing coronary artery disease was lower compared to your compatriots. So low dose sulfonylurea like state stimulation might actually be beneficial in reducing central adiposity, preventing coronary artery disease, and we did a sort of review looking at all the genes that could be related to the use of sulfonylureas. In the future, possibly we might be able to predict as to which individual has a higher risk of hypoglycemia with sulfonylurea, which individual will get cardiovascular benefit when sulfonylurea is used. But till that time, I think we do have a lot of data to say that the modern sulfonylureas like Glimepiride reduce blood glucose effectively, possibly more effectively than the DPP-4 inhibitors, at least during the initial phase of therapy. They might give us some pleiotropic benefits. With Glimepiride, there is evidence to suggest that it reduces insulin resistance at the peripheral level, and importantly, if you look at it from the practical point of view, a sulfonylurea like Glimepiride is here to stay until we get a better sulfonylurea to replace it. Without it on a day-to-day basis, it would be impossible to reduce blood glucose effectively. Thank you.